Good afternoon. Okay. Yeah. Good afternoon, ladies and gentlemen. Welcome to today's webinar, where we'll be discussing unveiling the potential of new and less used commodities in PPH management. My name is Chukwuno Sonwo-Korie. I'll be the moderator for today. And it's my pleasure to welcome you all to this webinar, which is organized by the Federal Ministry of Health here in Nigeria, in collaboration with Smiles for Mothers Nigeria. Smiles for Mothers, for those who don't know, is a consortium made up of the Solina Center for International Development and Research and Clean Health Access Initiative Nigeria. And we focus on PPH, which is one of the leading causes of maternal deaths, both globally and even here in Nigeria. For today's webinar, we will be sharing lessons, insights from policymakers, researchers, and program implementers with regards to new and lesser used commodities in PPH. And hopefully this will eventually translate to saving mothers' lives. Today's webinar would have two components. The first bit will be presentations, where we would have Dr. Tunde Amode from Smiles for Mothers, Petra Proctor from the Concept Foundation, Professor Galadanchi from the Bayero University Kano, taking us through some presentations to share their insights. We will then have a panel discussion where we'll have Dr. Samuel Oyeniyi from the Federal Ministry of Health, Professor Nike Bello from the University College Hospital, Ibadan, Dr. Martin Joseph from WHO Nigeria, and Elizabeth Enajero from Life Bank, discussing some of these new and lesser used commodities. So to get us started, I would take an opening remark from our chief host, Dr. Binyere Bukire, the head of the Reproductive Health Division at the Federal Ministry of Health, Nigeria, and she's ably represented by one of our panelists, Dr. Samuel Oyeniyi, who is the head of the same motherhood branch in the Reproductive Health Division. Dr. Oyeniyi.
Thank you very much. Thank you. We really appreciate Smile for Mother, the collaboration between the Federal Ministry of Health to bring up this webinar. My name is Dr. Samuel Oyeniyi. I'm a director and head Safe Motherhood, Federal Ministry of Health. I'll be representing the head of Reproductive Health Division, Dr. Binyere Bukire, who are the commonest cause of maternal mortality now in Nigeria, is worth doing, and every effort must be on deck to make sure that women do not die anymore from postpartum hemorrhage. So we are glad to be part of this, especially the topic, exploring breakthrough in PPH management, unveiling the potential of new and lesser used commodities. In fact, we made it known that interventions that will lead to reduction of maternal mortality, especially looking at postpartum hemorrhage, pre-eclampsia, and post-abortion care, These are the three leading causes. We are open to discussion, we are open to support any intervention on these three areas to reduce maternal deaths in Nigeria. If you look at the maternal mortality ratio, it's also unacceptably high and is becoming an embarrassment in the meetings. By the time we talk about the Nigerian maternal mortality ratio by NDHS of 2018, which is 512 per 100,000 live births. And to look at the other causes, PPH is contributing of that 23 to 24% of it. But we are gaining ground. A lot of effort has been on ground to reduce postpartum hemorrhage. And that effort is yielding results seriously. And I can seriously tell you, with the data available to us, the data we collected from tertiary institutions is 11% as a contributor to maternal mortality in our tertiary institutions. And we believe by the time we finish the 2023 NDHS, we'll be having a better result from it. But we're not done yet. We're not done yet. We want to bring it to zero. No woman should die giving birth. And knowing this, Federal Ministry of Health has done a lot to ensure that we reduce maternal mortality by reducing to zero their causes, the maternal health complication. We've been able to develop the safe model strategy where all interventions have been agreed on, and it will go out for people to be able to use those interventions to reduce maternal mortality. And following it, we are on the verge of developing, of analyzing guidelines for postpartum hemorrhage, the national guideline for postpartum hemorrhage, pre-eclampsia, eclampsia. We have developed the post-abortion care guideline. So we only have the postpartum hemorrhage as national guideline and the pre-eclampsia, eclampsia to complete. So we are glad with the effort of the partners. We are very happy for all their efforts to get this done. In addition to that, we are also one of the countries that will be implementing ending preventable maternal mortality and the ENA. So we're also implementing in Nigeria. And we've developed maternal and newborn health acceleration plan. And this plan is being implemented, and we are already looking into that plan, how we will be able to complete it in the next maybe 18 months. So with all this effort put together, we are calling on partners, calling on CSOs to join the effort of the Federal Ministry of Health and Federal Government of Nigeria to achieve the goal and the target we have set for ourselves by 2030. And with this topic, if duly enhanced, duly implemented, looking at the lesser commodities that are being used, we can do that, put them together against postpartum hemorrhage. I think it will be a beginning to the end of the reduction of maternal mortality in Nigeria through the zero tolerance to postpartum hemorrhage. With this, I want to thank everyone, those that are online, that have joined this webinar. that as we contribute to this, that we should listen, well, make contributions, and the Federal Ministry of Health will be taking notes and be able to see where we'll be able to take off from here. So thank you very much. With this, I want to declare this webinar open. Thank you very much.
Thank you very much, Dr. Yemi, for declaring the webinar open and also giving us some insights into what the Federal Ministry of Health is doing with regards to maternal health in general, but even PPH specifically. And I believe we will hear some more from you when we get to the panel session. So I would shortly introduce the next section and presenter. But I would like to just make an announcement to everybody on the call. So for our presentations, to save time, we will be addressing questions for the presentations through the Q&A chat box on the Zoom app. So we won't be able to respond verbally to questions for presentations, but for the panel discussions, those we will respond to verbally. So please note your questions as the presenters are presenting and feel free to type them in the Q&A chat box at the bottom of your screen. So the first section will be hearing from the Smiles for Mothers program. First, using a video documentary to showcase some of the work Smiles for Mothers has done, and then we'll take a presentation from Dr. Tunde Amode, who is the service delivery lead for Smiles for Mothers. So let's sit back and enjoy this video.
Also working with 3 states in Nigeria: Kano State, Lagos, and Niger states. Smiles for Mothers aims to reduce maternal death due to postpartum hemorrhage. The program is being executed in close collaboration with the Federal Ministry of Health, also working with 3 states in Nigeria: Kano State, Lagos, and Niger states. The aim was to work with the states to come up with context-specific innovations that the states would then implement to achieve the objectives of reducing postpartum hemorrhage and maternal deaths. One of the early innovations that Smiles for Mothers worked with the states on was introducing and adopting a recent WHO guideline that makes recommendations on the use of uterotonics to prevent postpartum hemorrhage, making sure supplies of good quality uterotonics were available, making sure health workers had the capacity, and even some efforts we did in terms of making sure patients were literate, as well as monitoring clearly what we're doing to measure the success. The very big challenge states were facing was having appropriate uterotonics available in the right quality, at the service point to serve the mothers.
Our main function is to develop policies and guidelines that guide different operations, how we put up interventions at the national and the sub-national levels. Check guidelines from WHO as they are coming out and adapt it to our local environment, and we run with it. Some of these include focusing on what we call active management of third stage of labor.
A key part of the Smiles for Mothers program is to strengthen national and sub-national stakeholder capacity to apply human-centered design to plan for the introduction of new innovations, new capabilities, and enhances existing capabilities of a wide range of global health actors by equipping the teams with new tools and methods to understand users, collaborate with them, and design interventions in a more efficient way.
Great innovations are good, but if they don't really achieve scale and reach everybody that needs them, then they never really have the desired impact. So on Smiles for Mothers, we're spending quite a lot of effort thinking through what does it mean to achieve scale? What does it mean for more people to learn the lessons that we have, learning from our experience to get the mothers of Nigeria the care they need. Part of what we've done is to make sure, as part of documentation, first of all, we developed what we're calling a Smiles for Mothers program playbook, a guide document on the steps we took, and then capture specific experiences we had, the kind of results we got, but also lessons for whoever wants to take it and apply. That will be very useful for policymakers, health managers, and even implementing partners that are looking to strengthen care in terms of postpartum hemorrhage, but also for other public health interventions, because some of these lessons are very transferable.
For the state, since the consortium was only able to reach a limited number of people, it's something that we would adopt and then further train more healthcare workers.
Heat-stable carbetocin is one of the SKUs at the Lagos State Medical Store, and is also part of the Lagos State Essential Medicines list. We ensure that there's always funding once it's in the Sustainable Drug Revolving Fund scheme, to ensure that it's always available. The capacity building trainings we had to ensure that there's a continuous training of health workers, new and retraining also happens. We also want to ensure that the newly reviewed Essential Medicines list is disseminated widely across the states.
What we want to see is for carbetocin having been imputed into the essential medicine list for the state to be one of those drugs that will be procured and supplied by the state through the agency.
This will ensure that women have access to quality uterotonics in each of these states.
Okay, so Dr. Tunde Amode will be taking us through the presentation on lessons from introducing heat-stable carbetocin by the Smiles for Mothers program. Dr. Tunde, over to you.
Thank you very much, Nanso. Good day, everyone. You're welcome to this webinar. Can we move on to the next slide? The Smiles for Mothers program, in the course of 3 years of implementation, has been supporting the Federal Ministry of Health of Nigeria, as well as 3 state governments of Kano, Lagos, and Niger to implement health systems strengthening interventions that have been aimed at reducing the occurrence and incidence of postpartum hemorrhage, as well as reduce maternal mortality. And in our first year of implementation, we had focused on ensuring that we have a conducive policy environment, which essentially centered around updates of normative documents, as well as update of the life-saving skills manual. We also interfaced with the regulatory bodies who had to secure approval for the excuse me, I can't see the slide, the presentation.
Sorry about that, Doctor.
Okay, so I'll just go on. And so we also did work to secure regulatory approval for the importation and the use of heat-stable carbetocin in country. And we went ahead and to the second year, which basically was using and leveraging the human-centered approach to program activities. And we were mindful of not creating parallel systems or structures. So we did leverage on what was available in the states to strengthen the processes. And these were all to support the use of
it's bucabitocin for PPH prevention in facilities across the country. During the course of the 3 years, we have collected comprehensive data through our monitoring and evaluation processes, and have been involved in various fora to share our learnings, to share the information we have synthesized from the data available, and to help decision-making across the various states and at the national level. Moving on, can we go to the next slide, please? So in our second year of implementation, we conducted an implementation research, which was focused at generating evidence as to the effectiveness and the use of adding HSC as part of the uterotonic option. And only not that, to have an idea and a perception of clinicians as to their impression after using HSC. So we worked in 18 public secondary health facilities across the 3 states. We had trained 177 healthcare workers to be able to use the new medications. It was already in use in Lagos, but for Kano and Niger State, it was new to them. We worked for 6 months, and at the end of the day, we did generate information describing what the current practices were in those facilities. We had a perception and understanding of how acceptable HSC was to the clinicians, which are doctors, nurses, and midwives. And we also did get an idea of what factors enabled appropriate use of uterotonic in facilities. So at the end of our study, there was an increase in uterotonic coverage overall. So we did move from seeing 90% information or data in the register going to 100% record for HSC and other uterotonics administered for during active management of third stage of labor. And HSC moved from use of 16% only in Lagos to the coverage of 70% across the 3 states. Very informative is that in Kano and Niger State, we actually had a rate of up to 89% as well as 83%. In that period, when we looked at records around PPH events and PPH incidents, there was a drop of about 36.5%. This is also informed by the fact that we did draw awareness to that issue around blood volume quantification, which was often underestimated. Professor Galadanchi will be giving more on that during the emotive work. And when we talk about perspective, the healthcare workers were and do think that HSC was actually very effective in reducing blood loss. And comparative to oxytocin and misoprostol, it wasn't too expensive, and side effect and safety profile was very comparable. Actually, some felt it was lower. So overall, we did have some lessons learned. And the lessons learned that we'll be sharing at various fora was that HSC as an option for PPH prevention was acceptable in Nigeria, at least at the states that we have worked in, as well as in other low and middle income countries. It can also be used, of course, in the global north, which there are paper and evidences supporting that. So this gives us the opportunity for scale up, looking at the various evidence that have been published around oxytocin quality, as well as misoprostol quality. One major learning point for us was the need for training and on-the-job mentorship. This helps healthcare workers to appropriately use the uterotonics as indicated. So throughout our course of work, HSC, which is contraindicated for augmentation or induction of labor, was not used by any healthcare worker for those indications. That was a major learning point for us. And finally, we had applied multi-pronged approach to our work. And of course, as WHO had said, oxytocin remains the gold standard. But looking at the context, looking at the spread of cold chain, infrastructure, quality of medication, HSE will fit into our setting. But notwithstanding, there has to be more work done on improving cold chain and also ensuring that supply chain issues and supply chain function are optimal across our facilities and across the country. Next slide, please. So one major question that keeps coming up is how cost-effective is stable capitocin? What price, what cost, at what cost does it come to the system? At what cost does it come to the woman? And so in line with this, we did have a cost effectiveness and budget impact analysis on when HSE is brought in and is used for PPH prevention. What is the effect on costs? And as stated in other studies, the uterotonics meta-analysis, as well as the Champions trial, even here in Nigeria, HSE comes at a lower cost to the system when we compare with the other uterotonics. This, of course, mainly or majorly predicted by the incidence of PPH associated with the use of other uterotonics. This paper is a preprint version. It's presently undergoing peer review, and once it is ready, it will be disseminated widely for everybody to read and have an insight. But meanwhile, you can scan and also look at the preprint version and look at the data that we have. We also, so in summary, in the course of the 3 years, we have worked in 166 facilities made up of tertiary, secondary, and primary health facilities. We have trained over 1,200 healthcare workers across those 3 tiers of healthcare, made up of doctors, nurses, midwives. We've also trained pharmacists and around issues on supply chain function, as well as uterotonics. We did also put in that bit around maternal perinatal surveillance and response, as well as pharmacovigilance, which before this training was really missing part of function in health facilities. To ensure that we improve knowledge and awareness around the reproductive life cycle, as well as uptake of services in facility, especially in facility deliveries and access to quality care. We did develop patient literacy materials, which was distributed widely across the communities where we were working. And presently, that has been shared with other partners and government officials, and is being used to raise awareness and for the expectation of care during and after delivery. 35,147 ampoules of HSA have been administered so far across our implementation research facilities, as well as other facilities that we're working with and are scaling up to. So overall, we've been able to have about 1,220 women have access to quality care. And that, of course, will also feed into the figure for achieving the SDG 3.1, which is the universal healthcare coverage overall. So for going forward, our next steps is we've been working with the federal government of Nigeria, especially the Federal Ministry of Health, to identify states to start the scale up to. And with that, we've identified 12 states across the country, across the federation. And of these, we have 2 political zones. So from there, we were looking to have the full coverage of the country, as well as sub-Saharan Africa, as well as the whole of Africa. And what we're doing is to help support with the policy updates of documents, ensure that we have commodities coming, HSC, oxytocin, misoprostol, as well as other maternal and newborn commodities. And of course, retraining and training of healthcare workers is very key to success. And so we will continue this work. And with this, we're also interfacing with private sector, as well as other partners that are working in the maternal and newborn space. So, in conclusion, we have done this work for 3 years, and we know that if we don't have records and documentation for this to be replicable, we would not have optimize the opportunity that we have been presented with. And so with that, we did come up with a playbook. And this is an interactive, better online tool, which allows you to have access to processes, methods, findings, and for the various tools that we developed. So the training curriculum, the training modules, patient literacy materials are all encompassed here. And you do have access, you do have the opportunity to access that if you scan the QR code, and you can replicate this and use or apply and adopt as necessary. I would like to thank you for the time you've provided and the opportunity to share our work with you. And please do have a great day. Hi, Nonso.
Thank you very much, Dr. Tunde. I think that was a very good one, sharing the experiences of the Smart from Others program, both in terms of implementation research, but the actual implementation of introducing his stable capital-C. I also hope participants were able to appreciate that beyond the Smiles from Others states that Dr. Tunde mentioned, stable capital-C has been introduced in a few other states, which we will hear more on during the panel discussions from Elizabeth from Life Bank. And that work was also funded by MSD for Mothers. So thank you again, Dr. Tunde. We will now move to the next presentation, which will be taken by Professor Hadiza Galadanchi, who is a professor of obstetrics and gynecology at the Bayero University, Kano, where she also doubles as the director of the World Bank supported Africa Center of Excellence for Population Health and Policy. For some of us in the maternal health PPH space, we might recall that Professor Galadanchi recently shared her work at the Goalkeepers event at the last UN General Assembly, and she will be doing the same today, where she'll be talking to us about the emotive trial, where she was, for which she was the principal investigator in Nigeria. Prof, it's a pleasure to have you, and over to you.
Thank you very much. Can you hear me?
Yes, ma'am, loud and clear.
Oh, okay. My network seems to be disappointing me. I'm going to off my video so that I will reduce the bandwidth so that I can make the presentation without.
So, Prof, you are muted.
Yeah, I'm okay.
We can hear you now.
Yeah. Okay. So thank you very much for inviting me to share the key highlights of emotive trial and its implication for maternal health policy and practice in Nigeria. Trying to move my slide. All right, so my outline is going to be one, addressing why did we have emotive, and then explain the concept of emotive bundle and describe the bundle, the emotive components, then the emotive trolley, and then what's the implication in Nigeria and how do we move forward? I mean, I've had the presentation from the representative of the head of reproductive health or head of family health, Dr. Oyeni, and then the last presentation on capital-C. So we're just moving on to add to what has been said. Now, I'm sure we all know, because it seems as if we are the community of maternal health, so we all know about PPH. We know why we're worried about PPH. We know why we're spending so much of our time and money and effort to see that we reduce postpartum hemorrhage. We know that about 14,000 women would develop PPH every year, and out of them, about 70,000 would actually die from it. And between about 6 years, we had almost 500,000 women dying from it, and 99% is in low middle income country. And right now there is a map that is going around in the global health that shows Nigeria to be red. In fact, the only country that is red, showing that a lot of the PPH cases come from Nigeria. And And it's very simple to understand. We have high fertility, we have high population, we have high fertility. Our TFR is very high, and then the PPH incidence is very high. That explains why we are right in that. And we need to do something if we really want to change the global picture of PPH. And we know that there are effective preventive steps. We know that active management of third state has been there since before we were students. And we know that the oxytocin we have should be able to prevent PPH, but we know the challenges. We also know that the diagnosis of PPH is very poor. And this is from the Champion data. The Champion data showed that 75% of women that have lost up to 500 mils, which is our PPH, are really not given any drug because nobody picks them up as PPH. People think it's normal because of the way we estimate blood loss, because we underestimate the blood loss. And then treatment is not initiated because you don't make a diagnosis. You only initiate treatment when you have a diagnosis. And then one of the important things we noted is that the treatment we have, which are so many, we've just had the cabetusin for prevention, we know oxytocin, we know tranexamic acid, we know misoprostol, but they are all delivered sequentially. And that is why we have the poor outcome that we are having. As I said, we know tranexamic acid would reduce 1/3 of women dying from postpartum hemorrhage. This is the women trial. And we know women trial has been there for so long, and WHO has updated its guideline based on women trial. And then we have the Champion trial. The Champion trial showed that cabetusin is as good as oxytocin. And where we don't have quality oxytocin, as we've heard this morning, with all the challenges of cold chain, then cabetusin, heat stable cabetusin is an option. Now, it is important for us, this is an important message, and I want everybody to carry this along. Emotive does not bring any new intervention. It is the same intervention. We're not introducing any new drug. We're not introducing any method, any way of a different treatment of PPH. All we are doing is having a new approach to how we detect and manage people with PPH. There is nothing new. All our interventions have been proven and they've been used in the system. It's just that we want a new approach. And what is this new approach? The new approach is one, it is early detection. And as I've just said, about 75% of women are not detected as having PPH, 500 mils and above. This is Champion data. And even at 1,000 mils, which is severe PPH, only 75 are picked, which means 25% also go missing. A woman has lost 1,000 mils, but nobody starts treatment for her because they think it's less than 500 mils. And that is the truth. We've tried it over and over, and we have shown that people cannot estimate the amount of blood loss visually. It is not possible. We need to detect it early. So we have developed, there has been so many different methods of calculating or of really knowing the blood loss. And what we have used in Emotive is just a drip. A drip will be placed, and the drip can actually tell us exactly the amount of blood. The next approach, which is totally different from what we're used to sequential. You have already given your prevention, then patient starts bleeding. You give oxytocin, hoping she will bleed, waiting for 30 minutes to see whether oxytocin will work. If it doesn't work, you go for tranexamic acid, another 30 minutes to see whether it will work. It doesn't work, you now put an IV line and put the oxytocin and give misoprostol, waiting for another 30 minutes, 1 hour. 2 hours, your patient is still bleeding. Definitely she will bleed almost the whole lot of her blood. And then finally, because the bleeding will continue, you now decide to go to the theater. 3 hours before she gets to the theater, and therefore we lose her. So what we are saying is that we need to do all this treatment within 15 minutes. Now, let me just talk about this early detection. We said usually what we do is visual estimation and then maybe blood pressure until she starts saying she's feeling dizzy and so on. So now we have a calibrated drip. It gives us the exact amount of blood loss. We check the blood pressure as well and the pulse, and therefore we act quickly. And how do we act? We give all the bundle in 15 minutes, which means you do the M, which is the massage, you do the O, which is oxytocin. Any oxytocin you have, is it oxytocin? Is it misoprostol? And studies are being done now to see whether carbetocin can also be used for treatment. We know that we've used it for prevention, and that is what it has been approved for. But any oxytocin is what is the M. Then, of course, the T is the tranexamic acid. The I is the IV fluids. And the E is examination and escalation. So you're given all these drugs and the patient is still bleeding, examine and escalate. So within 30 minutes, 20 minutes, your patient is in the theater if she's still bleeding. If you've given her 15 minutes, bleeding will stop. If she's still bleeding after 15 minutes, examine. It might be a laceration, it might be retained product, it might be ruptured uterus, it can be coagulation problem. Then decide the ultimate treatment. If need be, take her to the theater. If need be, take her to a referral system. Take her to the next level. What we're saying is that within 15 minutes, our women will all be treated. If need be, you escalate and get the right treatment. So all the bundles, the interventions in the bundle are given regardless of if you give one and you think it's working and it's going to stop. Give all of them. Give the oxytocin, give tranexamic acid, give misoprostol. Some of us give oxytocin and misoprostol. We're so used to it because we know oxytocin doesn't work. It doesn't matter. Give that. Give the IV fluid with oxytocin moving, and then make sure you examine your patient and examine and escalate. If you're alone, you can do all this. And a midwife can do all this. A midwife can give injections. A midwife can set an IV line. That is our tax shifting in Nigeria, and that has been approved. And that is why we're even thinking we can get to the primary healthcare centers that have midwives that can give this bundle. That is where our patients come, and by the time they get to the referral system, they've already lost so much of their blood level that even if we do anything, we lose them from coagulation abnormalities. Of course, you need to have help. If you're not alone, you have others, please call for help. The first thing we teach every healthcare provider in PPH is call for help, and then you can all do these things together. Now, for you to make sure that you implement emotive, we've also done implementation strategy in our trial. And one is that you must have a trolley, or you must have a table where you have every single drug that you will use for emotive, every single equipment and commodities that you need on the trolley, so that the trolley, you just wheel the trolley to where the patient is, or take the carry case to where the patient is, or bring the table close to the patient and make sure everything is there. You don't need to go and buy oxytocin if there is no oxytocin probably, or you have to go to the pharmacy to go and get tranexamic acid, or you have to go to the pharmacy to buy IV fluids. Everything should be on the trolley. This has really helped us in implementing emotive. We've got to do training. Our healthcare workers are used to sequential treatment. It was very difficult to change to this approach, but we're able to do it, so we can do it if we want to do it. We want champions, we want people to be in the health facilities that will champion this and make sure that this are done. They mentor the healthcare providers, they supervise them, they monitor them, and they assist them. That is what we need. We need champions. We need PPH champions across the country. And then we need audit and feedback. We give back to the healthcare providers what they have done, so that they will be happy that these are the people that they have saved. And this is what we did. Now we have published this in the New England Journal of Medicine, and it is there. New England Journal of Medicine is the highest journal in medicine that you can publish your trial, and therefore only a trial that is done absolutely with quality gets to that, and that we have done. We have published it in the New England Journal of Medicine. We have presented in the International Maternal Newborn Health Conference. We have published, we have presented in FIGO, we have presented in Sorgon. So a lot of dissemination is being done. WHO has taken it up, and I will be sharing what WHO has done with that. Now, the most important thing in that paper is that out of the 48,678 women that actually were in the intervention, because our intervention was in 80 health facilities. And ladies and gentlemen, out of those 80 health facilities, 40 were in Nigeria. So the data of emotive is Nigerian data. We contributed almost 100,000 deliveries in the 200 and something thousand deliveries that we were. So emotive is a Nigerian data, and therefore we should carry it and start running. It is our data, it is our women, it is our researchers that did the study. And it is now a global, it's been acknowledged globally. Now in the intervention clusters, there were half intervention, half control. So in Nigeria, there were 20 intervention, there were 20 control. The total 80 facilities, which were from Nigeria, from Kenya, from South Africa, from Tanzania, these are the 4 countries that participated. We had a total of almost, as I said, 200,000 plus deliveries. 48,678 were in the intervention. And out of them, those that had severe PPH, 1,000 mils, there were 794. In the usual care, so what we did was that we provided all the interventions that are for, all the commodities, tranexamic acid, IV fluid, everything in the facilities that were doing usual. But we didn't train them on the approach of emotive. So they were just doing their usual care. And out of that, 50,558 in the cluster, in the health facilities, we had, in the numbers of delivery, we had 2,139 that had severe PPH. Without doing any statistical analysis, you know that the usual care has gone how many times more than the intervention? Now, doing statistical analysis, it showed that there was 60% reduction in the intervention of severe PPH. You're not talking about normal PPH, severe PPH, because our primary outcome was severe PPH, laparotomy, or maternal death. That's our composite outcome. And 60% reduction. That is amazing. We went to look for only 25% reduction, but we got 60% reduction. So if Nigeria will adopt this, that red dot that is on Nigeria in the map will completely go white if we're to reduce 60% of our women that are having PPH, and therefore 60% of women that are dying from PPH, which is a quarter of all the women that are dying. That is the statistics, ladies and gentlemen. Now, so what is the implication in Nigeria? The first is that even WHO have taken it up. In fact, I have an internal knowledge that WHO has set up a committee that have looked at the data from emotive. They have already updated the guideline. The guideline of PPH is updated. We have a new guideline 2023, and this December is going to be launched. In this December is going to be launched. At the same time, there was a roadmap that was developed, WHO roadmap. Dr. Oyeni knows about it. He was part of the participants that were in Dubai for the PPH summit, and we developed a roadmap. And in that roadmap, it is clear that anytime there is a new intervention, WHO should take it up and update its guideline because it's a living guideline. And that is what they have implemented. And there's more research to be done for, new innovations. So already we have emotive in the guideline. Now, if emotive is in the guideline, what is next for us in Nigeria? It's for us to also update our guideline. I'm sorry to say, we really don't have a national guideline for PPH, but we have a Society of Obstetricians and Gynecologists PPH guideline, which is like a national guideline. Therefore, we can take it up and make it a national guideline, not only for the society. And I'm hoping that as soon as we get the PPH from the guideline from WHO, within the first quarter next year, we should be able to have a national guideline with an updated information with emotive within it, and any other information that is there. It is a living document as we have agreed in the roadmap. So we hope that we will have a guideline by first quarter of next year. And for us to, after that, the next thing is to implement the guideline. Now, when we did this emotive study, we did evaluation at the beginning. Most people didn't know about even the WHO 2013 guideline, which is the old guideline. Nobody knew about it. Those that know about it, they have not adopted it in their facility. They don't have a protocol in their facility based on the guideline. And therefore, there is no implementation. As you know, implementation is our major challenge in Nigeria. If we can tackle implementation, we will be running in terms of achieving our goals. It's just implementation. We've just got to find a way that we implement what we have, whether it's a policy, whether it's a guideline, whether it's a strategy, whether it's a protocol, we need to know how to implement it. So we need to scale up implementation of this new guideline across the country. And I had a meeting with the Gates Foundation and the Ministry of Health and the Honorable Minister of Health. And he promised us that as far as PPH is concerned, that is one of his first priority. He promised that there will be training across the country and there will be production and sourcing of drapes. Drapes will be sourced if we have to source them, and we encourage local production of the drape. Of course, for scale up, you need to engage all stakeholders. All of you that are on this call, you are stakeholders, whether you are whether you're a Federal Ministry of Health, a policy maker, an international association, a CSO, a healthcare provider, a woman, an academician, a researcher, a donor, an industry. You are all stakeholders, and we all have to be together for us, and collectively we should be able to achieve that. We've got to continue to do the training. The minister has promised us that training, he will support training across Nigeria, because we don't want any more study. This has been done. Scale it up across Nigeria. We don't want one country or one state or one local government. We want it across. The sites we did e-motive were across Nigeria. The 40 sites represented each of our geopolitical zones. Each of our geopolitical zones were represented in those sites. Therefore, there is no need of trying any other thing. It's for us to just implement, scale it up across the country. And of course, as I said, provision of the drapes and as well as local production. Then, of course, we'll continue to do monitoring, we'll continue to do supervision, we'll continue to do mentoring, and we'll continue to do evaluation. And I think this is the responsibility of each one of us. I tried to make this presentation as short as possible because I know that we have limited time. So ladies and gentlemen, early detection and treatment of postpartum hemorrhage using the WHO motive first.
Okay, it seems we lost Prof.
Response bundle is the answer to reduce the maternal health community, which are all ensure national scale up. Thank you very much.
Thank you very much, Professor Gadanchi. I'm sure we could all appreciate the passion in Prof's voice, but PPH is really a very, very important issue. I just want to point out a few things. I think some of the things Prof mentioned would get into in the panel discussions, the PPH roadmap, WHO's role, Federal Ministry of Health's role, the PPH guidelines. So let's all stay tuned and pay good attention to those, because I'm sure they will come up during the panel discussion. I know the conversation has mostly circled around our experience and journey here in Nigeria, but I do believe our international participants can definitely gain some insights from our experience here. And to also point out that some of the resources are being shared currently on the chat, in the chat box. I see the link for the PPH roadmap was shared, but also rest assured that all resources mentioned by the different presenters and panelists will be shared after the webinar. So we will quickly move to the next presentation. We are unfortunately, I think 10 or 15 minutes behind time, so we'll try to move a bit faster. So the next presentation, which will be taken by Petra, who is a clinical pharmacologist and works with the Concept Foundation. She will be talking to us about the costs of poor quality teratonics to the health system. So I'm sure most of us within the system understand the challenges with the quality of medicines in general, but she will be talking about teratonics, but even showing us some interesting insights about what it costs both financially and otherwise. So Petra, over to you, and we would appreciate if you could give us an abridged version of the presentation. Thank you.
I will. I'll do my best. Thank you so much. You can move directly to the next slide. Thank you. So I will do my best to go quickly. What I'll do is I'll stick on this slide, and then I might ask you to skip forward a few slides so that we can jump into the meat of things. So thank you very much for that warm introduction, and greetings to our distinguished guests and stakeholders and colleagues. I'm honored to be invited to speak on this webinar and to share the outcomes of this exciting work we have been doing, my apologies, that we hope very much contributes to the broader ecosystem and PPH effort in Nigeria. So this presentation is going to focus more on the existing quality issues relating to uterotonics, but as mentioned, coming from the economic perspective as well as the health outcomes perspective. So this means really looking at how much it is potentially costing a country health system when poor quality uterotonics are used instead of quality assured commodities, in the context that each instance of a medicine failure or adverse reaction, this is incurring costs to the patient's families, in the form of out-of-pocket costs in the moment, also to the healthcare system, the providers, and also the payers responsible for financing healthcare. So we have been working on this project for almost 2 years, and we focused this work on 3 country case studies: Nigeria, which I'll be going through today, Ghana, and Senegal. Today's presentation will focus only on Nigeria. You can go forward one to another one. Next one, stop there. Okay, so I'm going to try and abridge the sort of next 5 slides as quickly as I can. So this project we've been leading it at Concept Foundation, but we've been working very closely in collaboration with the University of North Carolina in the US, specifically the Eshelman School of Pharmacy. And the project essentially has been focused on developing models in each of the 3 countries. And these models are designed to estimate the economic and health impact. This work is very much anchored in the principles of universal health coverage, also the SDGs. It's also based on previous work that the University of North Carolina has done that has successfully linked poor quality medicines in health systems with a lack of progress towards universal health coverage. As we all know, as well as the health element of universal health coverage, there's very much a cost element as well, that no person should be able to not afford their quality healthcare. So this work is, in summary, designed to add to the current health argument, the current context that Professor Hadiza very clearly went through in her previous presentation, and the reason we're all here today. Not just that PPH is killing mothers, but also it's having an economic impact on the countries where it is most prevalent. And we wanted to design models that would strengthen this argument and also give actual numbers to policymakers in countries to be able to convince the country stakeholders to make policy change towards use of quality assured uterotonics, so that you can actually see how much a country could be saving. So that's going to be the most interesting part of this presentation. So I'm going to try and get straight to that. I'll quickly go through how we developed the models, what data we used to put into the models. And I also just want to mention that as I go through this work, I'm very much representing a much bigger team of hard workers, in particular the colleagues at University of North Carolina. I also do want to give a shout out to Professor Hadiza, who contributed to this project, in particular on the cost and utilization elements. Without further ado, I'll jump straight towards the model itself. I believe these slides are going to be made available, so hopefully you can have a look back through if you are curious to see what I skipped through. So starting with the model flow diagram, what you can see on the slide is the overall model flow going from left to right. The model begins with an annual estimate of the number of pregnant women in Nigeria. Pregnant women in the simulation faced a probability of the place of delivery, so public hospital, primary healthcare center, private hospital, or at home, and also the mode of delivery, so vaginal or C-section. So to capture some of the heterogeneity across the population, maternal background characteristics such as age, urban, whether they were living in an urban or rural residence, the region of Nigeria, the wealth quintile, education, and also national health insurance status, these were all incorporated to represent the distribution of birthing mothers across places and modes of delivery. We then also simulated the use and the quality of uterotonics. And when I specifically in this model, when we talk about uterotonics, we are referring to misoprostol and oxytocin only, just to be clear on that. We then estimated the risk of PPH. So this is, I'm now on the yellow section, circle, the risk of PPH and diagnosis, the associated health outcomes, and then the associated economic outcomes, which did vary by place of delivery. You can move to the next slide. So this is really just to illustrate this. The text is tiny, I do apologize. So it's really just to illustrate in another way how the decision tree model was set out in decision nodes. The top of this, you see it kind of splits into two parts. The top represents mothers delivering in facilities, and the bottom part represents mothers delivering at home. So as I mentioned, this starts off on the far left, that line coming out is pregnant women, then moving into different probabilities of place and mode of delivery. Also the use and quality of the uterotonics, the risk of PPH diagnosis, and then the associated health outcomes and economic outcomes. So just to explain a little bit more, the mothers in health facilities were simulated to receive quality uterotonics, substandard uterotonics, or no uterotonics at all, for preventive use for management of PPH. As mentioned, the uterotonic agents simulated in this model in our baseline include oxytocin and misoprostol, but we did simulate use of oxytocin alone, oxytocin, and also oxytocin and misoprostol together. Beyond PPH occurring and also PPH being severe, additional health outcomes included chances of receiving further uterotonic treatments, so increasing the number of medicines having to be used, which adds to costs, whether blood transfusions were required, whether postpartum surgery was needed, or whether maternal death happened. These health outcomes, again, varied by mode of delivery, so C-section and vaginal. We also simulated preventative uterotonic use and the use of preventative, the quality of the uterotonics used. So the economic outcomes included treatment costs to individuals, out-of-pocket costs relating to those treatment costs, and also blood transfusions, also costs to the government and productivity losses due to maternal death. And as mentioned, the bottom half of the decision tree shows home births, which did follow a very similar structure, but did assume that no uterotonics are given during childbirth at home. Now, we know that in Nigeria, this isn't always the case. We did simulate a scenario where misoprostol was being used for home births. The reason we weren't using this in the baseline was because we didn't have adequate data to be able to, meaningful data to go into this part of the model. So that was the only reason. So again, I'll reiterate, this is a model, and obviously it's going to have its limitations as well as its strengths. Next slide, please. So I'm going to very quickly go through the data inputs and then jump into the results, because I think that's the most interesting part for everybody. And I'm really happy that Professor Galdazzi already went through all of the emotive trial, so we're very familiar with that. I just wanted to mention that we were very lucky to be able to work directly with the University of Birmingham, who were able to provide Nigeria emotive data. And in relation to this study, we utilized it threefold. The first was to support our estimates on the risk of PPH occurring. Also, we used data to estimate the utilization of uterotonics, oxytocin, misoprostol, and then we also used emotive data to estimate the dose of oxytocin that was being commonly administered. You can go to the next slide, please. So other data that was used for the model, we used demographic and epidemiological data from Nigeria. Very quickly, we used a range of data sources, the UNDP, WHO, World Bank, and other literature. We also used the 2018 Nigeria Demographic Health Survey. You can move to the next slide. The next slide is about, the quality, the data on quality and use of uterotonics. So this came primarily from literature. We also used data from the emotive trial, as mentioned. So you can see the literature sources there. We use Dr. Edgecombe's paper from 2021, the emotive trial 2022 data, and we also used Professor Anyukora's data from 2018. Moving, you can go to the next slide. So finally, for the healthcare costs, we worked with key opinion leaders to be able to estimate costs in both the public and private sectors. And we worked closely with Professor Hidiza on this, and also Professor Anyukora. And you can move to the next slide, which I believe is starting to outline the results. So here you can see our very top level key findings. We have done a very detailed, we've written a very detailed manuscript, which has currently been submitted to BMJ Open. It's currently being peer reviewed, so we hope that will be published in Q1 of next year, and we will happily share that paper with you all. It will be open access, so you can see the detailed results. We're also very happy to share more results with anyone who would like to see them in more detail in the meantime. We have a set of slides that details things a lot further. So top line, our model, our model found that if we were to improve the quality of Utratonics, we could reduce the number of overall PPH cases in Nigeria on an annual basis by 75,000, the number of severe PPH cases by 18,000, and also the number of deaths by about 1,500. We think these numbers are quite conservative, and that actually, in reality, they're likely to be higher. And we know that if we were to mature the model a bit further and refine some of our data sources, we would probably be able to refine these numbers further as well. So this is an initial indication. From an economic standpoint, substandard Utratonic use is estimated in, at the time, bearing in mind that obviously there's been significant inflation. At the time of the model results, $89 million, which at the time translated to approximately 68.4 billion naira. And that refers to total cost of care modeling our baseline. Breaking this down, we have a breakdown of approximately 7 billion naira in out-of-pocket costs in the north, and a further 24 billion in out-of-pocket costs in the south. And additionally, 39 billion naira in long-term productivity losses. So ultimately, these results show us that ensuring good quality Utratonics would improve maternal health outcomes and result in millions of dollars in cost savings for the government and families in Nigeria. Cost savings from improving Utratonic quality would aid in advancing Nigeria toward universal health coverage. That is a certainty. You can move on to the next slide, which I will skim over. This just shows we modeled several different scenarios. You can see them all there. We modeled a scenario on use of quality heat stable carbetocin, use of misoprostol and home births, and several other scenarios, which are all detailed in the paper. If you're to put all of these savings together, in addition to the baseline, we're looking at over $100 million in savings for the country of Nigeria annually, if we were to prioritize use of quality assured Utratonics. And again, we believe these numbers could actually be more significant. I'm going to finish off by saying we believe that by quantifying the clinical outcomes and costs of PPH in the context of universal health coverage in Nigeria and estimating the costs, we're able to outline significant arguments that will support policy change or the ongoing work that's currently going on in Nigeria, in particular for the rollout of HSC. And then, sorry, you can go to the final slide, and then I'm aware of time, so I'm just going to wrap up. We've identified obviously some strengths and limitations. So on the strength side, these models are unique country-specific case studies that are demonstrating both the health and economic burden of the poor quality Utratonics. We disaggregate burden of poor quality Utratonics borne by payers and families. And these results, as mentioned, will contribute towards evidence to improve Utratonic quality in UHC and advance UHC. In terms of limitations, we did have limited data on the quality of Utratonics in some countries, also Utratonic use and the cost of care. And we did have limited data to account for population heterogeneity across health and economic outcomes. So with that, I will wrap up. I hope that was informative and helpful, and look forward to the panel discussion and answering any questions that colleagues may have. Thank you very much.
Thank you very much, Petra. I think that was really indeed insightful. I think these numbers are really important for just planning and implementing health programs, but even more importantly, for advocating to political leaders on the importance, of having quality clinics within the system. I'm sure the question and answer chat box will be popping with questions. So let's all remember to drop our questions there. Our presenters are still with us, Dr. Tunde, Professor Galadanchi, and Petra are here to answer any questions you might have. So please do feel free. We will move now to the panel discussion where we will go a bit deeper into some of the points that have been raised. We've gone through, implementation experience, we've gone through research, insights. So now we will get into some of the practical conversations around using these newer and lesser used commodities. For the panel discussion, I will be joined by 4 panelists who cut across different sectors. We have people that influence policy and guidelines, from the Federal Ministry of Health and WHO. We have a researcher with us. We also have an implementer with us. So this, I believe, is a very rich panel that would give us interesting insights. As a quick introduction, we met Dr. Oyeni earlier. He is the head of the Safe Motherhood branch at the Reproductive Health Division, Federal Ministry of Health. And he has interest in pediatrics, field epidemiology, health information system, in addition to maternal, newborn, and child health. And he has also published a few research papers in scientific journals. The second panelist with us is Professor Nike Bello, whose research work focuses on intrapartum and postpartum care. She was the lead investigator for the woman trial, which Professor Galadanchi mentioned earlier, and will be talking to us a lot about TXA. The third panelist is Dr. Martin Joseph, who is with the WHO Nigeria Country Office, where he's the medical officer for maternal and child health. He has over 2 decades of experience doing health work at the national and international level, and comes with some years of experience from Kenya, where he was a clinician for some years. And the final panelist is Elizabeth Enachero, who is the Vice President of Growth at LifeBank. LifeBank is one of the partners that has introduced histamic capitocin in a few other states in Nigeria. Elizabeth has experience working with different companies in the private sector like Health Plus Pharmacy and Health Tracker, and has experience cuts across procurement, supply chain, and operations. So join me in welcoming my panelists. I will start the questions first with the policy makers and the people who kind of guide how we deal with PPH in Nigeria. So my first question is going to both Doctors Sam Oyeni and Dr. Joseph. So the question is to just enlighten participants on what are the efforts that the Federal Ministry of Health, in the case of Dr. Oyeni, and WHO are currently playing in reducing PPH in Nigeria. So I'll start with Dr. Oyeni.
Thank you also for the question. Federal Ministry of Health has been very active in terms of reducing the maternal mortality. If you look at the trend of NDHS past years that we have conducted, we remember that there was a time when we were at 1,000 plus of maternal mortality per 100,000 live births. And over time, we've been able to, in the past decade, be able to bring it up to 512 now. So within this period, I'll just quickly itemize what we've been able to do that has given these results. Actively it started like a decade ago, let's say between 2013, 2014, when we started collecting active data on maternal mortality. And those data came in, or they've been coming in by states, by facility, by local government, that now help us to look at those data, how they come in each state, the contributing factors from the state, in the 36 to 37 states, plus FCT. And that the Federal Ministry of Health did through the establishment of maternal perinatal death surveillance and response in Nigeria. Many countries have used this program to reduce their maternal mortality. Germany did, Sweden, Norway. These are countries that have now have like 1-digit maternal mortality. So that has been proven a program that can be used to reduce maternal mortality. So government established that program by auditing every maternal death that occur in Nigeria. We developed the guideline, the National Council on Health approved it, and states adopted it, and we now operate it or implement it in all the 36 states plus FCT. I think that is the major thing that has seriously helped us. And with that program, we can now look at our data. State can look at local government, maybe senatorial areas where you have high maternal deaths, and you can now go to those areas and look at the factors that may be contributing and be able to tackle those factors. So one of the most important programs that government has established in reducing maternal mortality is the MPCDSR that cut across both maternal, perinatal, and child death in Nigeria. So that is a major program. And few years after, government also launched the quality of care program, where we now make sure that the product of MPCDSR, which the approach is also to improve quality of care, is also taken care of. And we want to appreciate all the partners in this space for what they've been able to do this past over 5 years, implementing quality of care in Nigeria. And presently, we have gone up to 25 states in implementing the program. So that is two things that are seriously helped us in these past years. And implementing these two, we supported it by developing safe model strategy, which was not there before. We've been doing a lot of programs, a lot of things, and the state needs guidance. And they've not been able to, because that is where implementation is. So we have come up with a safe model strategy that at the subnational can guide in what to be done, looking at the interventions. We've just listened to Professor Galadanji. That document contains the emotive interventions that will guide the states in what to do. Then when you look at the causes of maternal mortality in Nigeria, we have the highest of them is the postpartum hemorrhage, followed by pre-eclampsia, eclampsia, and unsafe abortion. So we have developed guidelines for implementation of post-abortion care, which we have launched, we have implemented with support from MIPAS. And the remaining two that we don't have the national guideline, just like Prof said, that we have the SOGON guideline. But for national guideline, we've not been able to develop. So federal government has entered into support from some partners, and consultant has been engaged for us to look at the guideline for postpartum hemorrhage. And that will house the use of terotonics and other items, the emotive, that will guide us for the management of postpartum hemorrhage as a national guideline. And we are also on pre-eclampsia, eclampsia guideline. As we have data, we need to step up implementation or management of pre-eclampsia, eclampsia means gradually overtaking postpartum hemorrhage from the data that we have. So government is also looking at that. In moving forward, we've also supported a lot of interventions, implementation research in this area. One of them is the capetocin that we have done in collaboration with Smiles for Mothers in those 3 states, and we'll be able to present it. We presented at Cape Town, and looking at the results that we have, and looking at the climate features of Nigeria, oxytocin is failing in some areas. When you look at in terms of the storage, there was a time we went to the field to look at the effectiveness of oxytocin. We took samples and they were sent for analysis. You'll be amazed what we have. Some of these oxytocin, they are on the shelf, and the temperature at which they are kept, if you look at the temperature or the environment in the northern area of Nigeria, for example, that has contributed to why we're having more PPH killing even after you are giving your oxytocin. They are not responding to it. So the environment, you need the colder environment to be able to store oxytocin and for it to be more effective. And in moving forward, we need an alternative that will be able to stop that gap. And that was why we look at this intervention, the introduction of carbetocin into the system. Though people have talked of cost, it's always like that to start with. With time, the market forces will bring that cost down. That we know. But when you look at the effectiveness based on the result that we have seen, so it's one of those things we are using or we have introduced for use, and the result has been very amazing. So apart from the uterotonics that we are bringing on board, we have also endorsed the emotive, which all this will be in our strategy. Now, in terms of human resource for health, it has been a challenge, and government is already looking. Before now, we launched tertiary policy, where nurses or doctors are not available. There are some of those tasks that have been limited to this cadre, can be taken care of by cadres that are available. And that has given us a lot of results, especially in areas where we don't have the scale-back attendance sufficient enough. So that policy has seriously helped in attending to pregnant women and subsequently the availability has contributed to the reduction of maternal mortality. What of training? Government has also stepped up the training. We have produced training manuals for life-saving skill. Apart from the curriculum we have stepped up for the pre-service, we'll be able to put a lot of intervention into our pre-service curriculum so that health workers can have that knowledge before coming out. And where they are posted to, they can do diligence when attending to pregnant women during antenatal care with a bid to reduce maternal death. So the life-saving skill training manual is for doctors, nurses, and CHUs that are in service. So it's like a 2 to 4 weeks training. And what government has also done is to establish 3 training centers, 1 center per geopolitical zone. This center has been there for some time. Some areas, some states, they have not been using these centers. We have one in Jos for North Central. We have in Kano for the Northwest. We have in Bauchi for the Northeast. And we have in Imo for the Southeast, and River State for the South. And we have in Ibadan for the Southwest. These training centers are equipped. I want to appreciate our partner UNFPA, WHO, for the support they are giving to this center. But of recent, those centers have not been made use of. The essence is to reduce cost of governance, of doing training, maybe in hotels, and those centers are built for this purpose, so that when you want to conduct training in the North Central, the state within the North Central, especially where those things are, should be able to use these centers. We have hostels, we have 2 classrooms in each of these centers. They are equipped with infrastructure. Generators are there, kitchen, hostel with beds and mattresses. But over time, some of these centers have been dilapidated, but they are not used. I remember for the one in Plateau, we had to take it over from the government has changed it to office use. And after then, we'll be able to do some training in this center. So it's important when government do most of these things, especially Federal Ministry of Health, it is expected at the state level where the implementation takes place, the responsibility is to take it up and use it as directed by the Federal Ministry of Health. It was adopted at NCH, these 6 centers. So we need to put together our efforts and make sure that these centers is upgraded now, and we'll continue to use it to increase the health workforce. Looking at the problem we're having now with human resource for health, so the people we have on ground needs to be trained. We've been able to modify the curriculum of the CHUs to also take something through TSTS policy. And those training of the in-service should take place in those centers, and even as a continuous education. Within the training also, we develop a low-dose, guideline for mentorship, training, and supervision at the state level. And that document is meant to guide also the state implementation in terms of training. And the guidance is that many of the health workers come out for training, didactic or classroom training. And once they are moved where we said there are no health workers enough, the essence is for them to use this guideline where we have introduced low-dose, high-frequency training, where there are the trainers are within the local government, and the states should monitor. And that helps to what? To train them while they are on their job. So a lot of states are already doing, supervising these health workers at the facilities. So those are the things we have also done. To add to it, we also developed community guidelines for community use of misoprostol, just to reduce maternal mortality at the community level. All the effort that has been made, we still have people at the community delivering at home through the traditional birth attendants. Apart from that, even those that are delivering at the facilities, Also, misoprostol is now part of the kits that they are giving as a birth kit for them to use during delivery. So we'll be able to do that and be able to make sure that this enter the essential medicine list for use at that level. Then other things we're also looking at is we are to forecast, quantify, and make sure that these uterotonics are available at the state level. There are a lot of stock out, and that is what we are doing, engaging the states, so that when we have these health commodities, they'll be able to know the quantity needed. A lot of stock out at the facility. So government has put in place and through our warehouses to make sure that these commodities are available. And the Federal Ministry of Health, like I said, has been doing a lot. If you look at the constitution or the policy that demarcate the Federal Ministry of Health and the State Ministry of Health, states that is where the implementation is. And they have responsibility to also do. We can do oversight. We can also encourage them, advocate for this. So by and large, lastly, the creation of the Department of Family Health at the subnational level is on coordination. The Federal Ministry of Health has been doing a lot in terms of coordination, getting information from the states, coming to tell us what they do as a central coordination that will also go to the states. So we established a RAMCA multi-stakeholder coordination at the federal level. And it is expected that the state will also have the Department of Family Health. And these were taken to the LCH, which was approved. The essence is to make sure that every state have this department that will coordinate maternal, newborn, and child health activity at the state level. And the goal is to be able to reduce maternal mortality. If we don't take that coordination serious, especially between the State Ministry of Health and the partners that are in the state, and that's the essence of approval for the Department of Family Health in all the states to coordinate and replicate what Federal Ministry of Health is doing in terms of coordination, to coordinate the activities. We are talking of APMN, we are talking of other global activities that are coming on. Yes, Federal Ministry of Health will take the lead, but state need to take up, because that's where the implementation is. So that coordination is very key. And for Federal Ministry of Health, we have done everything possible to make sure that the state establishes their Department of Family Health in all the states of the Federation to coordinate this activity. So by and large, from many that federal government has been able to do, these are the few ones that I can inform us for now. Thank you very much for the time.
Thank you very much, Dr. Ini. I think that was a very robust response that also covered, some of the challenges that, we face in Nigeria, but also, some of the forward-looking things that the federal ministry is doing. So I would hand it now to Dr. Martin, but Dr. Martin, before you respond, I would just like ask you, tell us about what the WHO is doing in Nigeria to also, talk about some of the things that have come up during today's conversation, specifically the EPMM, that's the Ending Preventable Maternal Mortality Strategy, and the PPH roadmap. Over to you, Dr. Martin.
Thank you so much, moderator, and good afternoon, colleagues. So what WHO is doing, if I can start, if you'll allow me to start with the global picture. I'll not go into the context. I think the presentations that have already been made have really set the stage on why WHO is ringing a bell on PPH. It is a condition that is largely preventable, but it's still contributing to 1 in every 5 global maternal deaths. So that's a huge thing. And then from WHO, we also look at it from the equity angle, that although this, if you look at the high-income countries, this is really not a problem. But when you come to the low, middle-income countries, that is where majority of these deaths are happening. So again, there's that equity angle that we are looking at. And I think Professor Gadalanchi mentioned that red dot on Nigeria in the global map. Again, the issue of equity. So we really need to not leave anyone behind. Then also from WHO angle, looking at the SDGs 2030, looking at where we need to go, reducing maternal mortality to 70 per 100,000, when globally we are almost at 223. If you look at Nigeria, much higher than that. So again, this sets the stage for us really to call for urgent action. And this call for urgent action is through the roadmap. This was mentioned. And in this roadmap, it has 4 strategies. And I think if you listen to Dr. Oyeniyi in his submission, he already mentioned aspects of this roadmap. Professor Gadalan mentioned the issue of research, the emotive. And while discussing that, she mentioned how in 2017, the guidelines were reviewed based on the woman trial. In 2018, they were reviewed based on the champion trial. And now in 2023, with this evidence from the emotive, again, there's going to be another review. Norms and standards, how do we set global guidelines that then countries can pick them up? And this should be evidence-based. I think this is one area that the WHO is also working on at the global level to really have these norms and standards updated. In terms of implementation, realizing that it's not just about having cabotegravir on ground or any other intervention, but really it's a health system issue. If you listen to Dr. Oyeni, he talked of MPDSR, he talked of quality of care, tax shifting, tax sharing, to ensure that the human resource is there with the right skills, with the right knowledge. He talked of the supply chain system to ensure that the commodities are there, but the quality and safety of those commodities are there correctly. Then the issues of access, both geographical and financial, ensuring that this service is available in Lagos, it's available in Borno, it's available in any state, in any facility that we go to. So how do we ensure that geographical access? Ensuring that the financial access is there. At the moment, we are discussing the renewed HOPE agenda. We are discussing the minister's health renew investment plan. How are we ensuring that these PPH interventions are part of those conversations on that table, so that when we come up with a benefits package, we are sure that this will be prioritized. We are lucky for us in terms of advocacy that at the highest level, this is something that the president and the minister have come out to say maternal mortality will be our focus. But as we go down, as you go to the states, is that the vision of every governor that in this state I want to reduce the maternal? So the issue of advocacy. So basically what WHO does is to translate these strategic areas or this roadmap at the country level. And I think Professor Dr. Yeni has mentioned how we have worked together to ensure that this research is translated in the safe motherhood strategy that we are finalizing. It's translated in the EPMM priorities that we are also working on to ensure that we have the guidelines. And I think I want to agree with Professor Gadalan. This needs to come as fast as possible to really take the evidence we have now, put it together, have guidelines to start working on. Guidelines are dynamic. As new evidence comes up, as changes come up, we again come together as stakeholders and review that. In terms of implementation, as I said, ensuring that at this time when we have new administration, when we have a new minister who is shaping the new agenda, ensuring that PPH, maternal mortality, is top on that agenda, and not just the words, but what interventions are we prioritizing and how much are we investing in those priorities? So WHO is ensuring that we are on that table, we're ensuring that that agenda is being discussed. And also in terms of advocacy, ensuring that we are actually, as we are engaging with the state governors through our state offices, again, this is an agenda that we are prioritizing. So in summary, this is what WHO is doing at the global and how we are translating it at the national level. Thank you.
Yes, thank you very much, Dr. Martin. I think that's very insightful. Just showcasing what WHO is doing both at the global and national level, and also provide some of that Nigerian context, especially around the autonomy of the states, where each state government needs to also set the priority. I'm also very happy that we have participants from different states in Nigeria. I'm hoping they're also taking notes and thinking of how to take this message back to their respective states. The next question is for my lecturer, Professor Bello. I know you've been involved in several clinical trials for maternal commodities, specifically TXA, and I also think heat stable carbetocin. We would like you to share, some very high-level insights from, some of those studies like the woman trial, and then tell us, some innovative approaches, that you think we as a country at the different levels can implement to scale up, TXA and even heat stable carbetocin.
Thank you, Dr. Nonso. Good afternoon, everyone. I'll make a quick disclaimer, if you'll indulge me. I was introduced earlier as the principal investigator for the woman trial. I wasn't. It was my mentor, Professor Bukola Fawole, who has since passed on. I worked with him as a local investigator then, and thereafter, after the initial woman trial, I've been the national PI for the subsequent trials, but not the woman trial. But I'm well familiar with it because I was a local investigator. And the woman trial was mostly a Nigerian trial, like the way Professor Galadanchi has said about the emotive trial. We had 20,060 patients in that trial, participants, and a quarter of them came from Nigeria. There were about 200 hospitals, about 193 to be precise, and about a quarter of them, 54 hospitals, were from Nigeria. So it was mostly Nigerian data. And that's why it's not surprising that a number of the things I've put together to say are the things that Professor Galadanchi said as well, because it's the same Nigerian milieu and what we've seen in doing research over and over in the place. The first thing I wanted to say is access, CXA supply. Now that works for all the other interventions too, except the low cost, locally, what would I use? The adaptable ones that you can make you can make with adaptable technology, like the drapes and things. But anything that's a medication, procurement is important. Now, all of us that are clinicians know that what is supplied, what is made available, what is imported and goes on supply chains are what we demand. Most pharmacies will do this on a demand method. They'll supply based on demand. They would not invest in making things available that will just tie down their resources, and doctors will not prescribe and hospitals will not buy. That's why our focus usually is on starting with the doctors. And that's what we have done by disseminating information to SOGON, to the Federal Ministry of Health. We got the guidelines updated then when Professor I.F. Adewale was the minister at the time. We've done redissemination over time. And this is what we found. And this is what makes me suggest the things I'm going to say subsequently. That CXA and probably carbetocin, when it's put in guidelines, it's easily taken up by centers in which guidelines are followed. Centers like teaching hospitals like UCH, where I work, which participated in these studies, where residents are trained. So they have to stay up to date with the guidelines nationally and internationally because they have exams to write and because our practice really must follow international guidelines. But that's not where most of the babies in Nigeria are born, really. And that's where dissemination usually ends. We talk at Sogon meetings, sometimes we talk at midwifery meetings, but most babies are born in primary care, really, in Nigeria. Only a small percentage of parturents make it to teaching hospitals to be delivered. So if these interventions are not available in primary care, in places where the skilled health worker is not necessarily a doctor and not always actually even a trained midwife either, then the bulk of Nigerian births will still miss these interventions. So one of the things I have shared, both with Life Bank and with Smile for Mothers at different meetings and think tanks that we've had, is that I think primary care should be a target. It had not been a target for our trials because, well, as researchers working in university and with university people, our focus was on disseminating to colleagues, but that's not enough. So introduction to primary care is important. And then even at the level of our colleagues, it's easy to forget. In one of our later dissemination meetings, which we're trying to do retraining, and we went around the country a bit, even in these teaching hospitals, when you talk to the doctor that's on duty, who is a resident, who reads guidelines, he reels off tranexamic acid as one of the interventions that he would use for treatment. But then when you now look at the emergency trolley, it's not there. I can say that for my hospital as well, as big as University College Hospital is. It's not necessarily on the emergency trolley. It's available in an in-house pharmacy. So it still is pay as you go. You buy it when it's needed. And we all know that in PPH and emergency care, that's not really what works. That it needs to be available on an emergency trolley. So it somehow in a pay-as-you-go setting, the cost needs to be inculcated in what you make available as each woman's package, as it's called in some places, for her delivery, right? So availability on trolleys, which is something Professor Galanjo has said for all the emotive intervention, is another thing that's important. I'll dash back to something I missed out when I was talking about supply. Another thing we found is that some of the available tranexamic acid preparations are of low quality. Imported, some of them are made, I won't take up my next say they were made locally. I'll say that they're distributed locally because the company names are usually local company names, but they were imported. And I do not know what would happen somewhere in that chain, but some of them are of low quality. They don't have enough tranexamic acid. Our partners took samples because we procured lots of samples and took them back to their laboratories and saw that most of them did not really have 1 gram, 1,000 milligrams of tranexamic in an ampoule. So that is also a problem. Now, if the supply chain is going to be made available locally, it will be easier for the oversight of ensuring that processes are done properly. I also wanted to say that tranexamic acid, well, I believe Professor Galanjo has covered that in her talk about emotive. The woman trial was about treatments, right, for postpartum hemorrhage, finding out that 3 out of every 10 women that had postpartum hemorrhage would not die, as it would be saved from dying. It will prevent maternal death in 3 out of every 10 women that get tranexamic acid in a timely fashion. By timely fashion, we mean that within 3 hours of the onset of bleeding, which is why the later emotive study that has been done has shown that you should give everything within 15 minutes is well in line with what we found in our study. But the subsequent trials that we've done are leaning towards prevention. The recently completed Woman 2 trial, we took a group of women that are at risk of PPH, anemic women, and we randomized them into getting a placebo or tranexamic acid. We are still analyzing the data at present. The study has ended, we're still analyzing, but what we're hoping to see is that it might show that prevention in women that we know are at risk for postpartum hemorrhage might be useful as well. I can't speak for that now as we have no data, but that was the purpose of the study. And the next study we're rolling out the I Am Woman trial, or I'm Woman, meaning I'm Woman, wants to look at other means of this of administering it. At present, it is administered as an IV bolus. And in most hospitals, it's doctors or highly skilled attendants that can give an IV bolus. So we are going to assess it against IM, tranexamic acid, which anybody that provides healthcare can be easily trained to give an intramuscular injection. So we hope that would help the rollout to other places that are not managed by necessarily highly skilled workers. Most of the interventions that are needed are mostly implementation, us paying attention to the processes that we already know. It's not about generally something exotic or new, but us paying attention to stick with the things that we know that work, and to keep doing the training and retraining. Now, like I said, SOGON members, that's Society of Obstetrics and Gynecology, a good number of them were investigators in the woman trial. But the woman trial is like, it ended in 2016. Yeah, 2010 to 2016. So it's almost 10 years old now. And each time we go back to talk about it and go to these hospitals again, we don't necessarily see it being implemented. So that's even just teaching hospitals, talk much less of the wide population. So I rooted for the motive trial while it was on. My center was not part of the motive trial because trials that were working in the woman trial couldn't work with the motive because it would contradict our outcomes. And I'm really glad of what they found. And I support this rollout that everyone should work with these interventions and early. And I'm looking forward to it being disseminated all over Nigeria. That's all I have to offer for now. Thank you.
Thank you very much, Prof. Also, thanks for the correction. I think that your contribution was really, really insightful, just reminding us, where the burden of PPH really is, which is outside, some of these teaching hospitals and other secondary hospitals that, have skilled health workers. I will now go to Elizabeth, who is our final panelist. So I think we've hinted during the earlier parts how LifeBank is, working to introduce stable carbitocin in a few other states. So I would like you to just give us an overview of LifeBank's efforts to reduce PPH and maternal deaths in general, and also share your experience, in terms of scaling up the Smiles for Mothers in strategy in the other states. Over to you, Elizabeth.
All right, thank you so much, Nonso, and thank you to the Smiles for Mothers team for inviting us to this event. So before I go through some of the work that LifeBank has been doing, I think maybe some people on the call might not know LifeBank. I think I should talk about LifeBank, who we are and what we have done in Nigeria and the countries that we do our operations in the last 3 years. So LifeBank, we're Africa's foremost healthcare technology and logistics company. So we work with about 2,000 hospitals in 3 countries, and we help them get access to critical medical supply. So supplies like blood, oxygen, consumables, and also medical equipment as well. So LifeBank was founded in 2016 by Kini Giwa Tubosun, and we have been in business for about 8 years. And in that 8 years, we're very proud of the work that we have been able to do. So we have been able to move about 182,000 products to about 2,000 hospitals in 3 countries. And also directly, we have been able to impact about 80,000 lives, which we're very proud of. As I mentioned, we have operations in 3 countries. We operate in Nigeria, we operate in Ethiopia, and we operate in Kenya. And our business in Nigeria, we're pan-Nigerian, so we have operations in 12 cities across Nigeria. And we're also very proud of the fact that we have never shut down. We run a 24-hour business. So our logistics staff are always making sure that 24 hours we're supplying hospitals with what they need. So concerning the Smart Access project, so Smiles for Mothers have been on this project since I think about 2020. LifeBank joined this project in 2023. And we have been active on this project for about 7 months. And we're very proud of the progress that we have been able to make in 7 months, also adopting a lot of the methods that Smiles for Mothers have used. So in terms of some key numbers, over the past 7 months, we've been able to train healthcare workers in about 4 states. And our training really has focused on pregnancy, on postpartum hemorrhage, and on uterotonics, specifically the newer and lesser used uterotonics, such as heat-stable carbetocin, which is one of the reasons why we're here. So we have 5 major states that we're doing this project in, just like Smiles for Mothers. So our project states are in the south, we have Delta and Rivers, and in the north, we have Kaduna, we have Jigawa, and we have Yobe State. So in the last 7 months, across these states, we've been able to train about 1,200 health workers. And we've done this using a mixture of models. We have done physical on-site training. And we also developed an e-learning platform that will enable us to get access to more healthcare workers. Also, in the last 7 months, also adopting some of the methods that Smiles for Mothers have used, we have had intensive engagement with the state governments across these states. Because what we are trying to do is ensure that we have proper buy-in from these state governments so that heat-stable carbetocin can be introduced into the states. So our engagements are going very, very well. We've started to see demand, and also using one of the methods that Smiles for Mothers did, we have seeded stock across these states to ensure that the healthcare facilities get the opportunity to try these products and see how it works, heat-stable carbetocin specifically. So one of the things that has been very crucial for us is demonstrating that heat-stable carbetocin is cost-effective for governments. Because when you approach state governments, one of the first things that they ask you is how much, yes, the product is great, it's very effective, it is heat stable, it doesn't have some of the limitations that oxytocin has. But when you look at the total healthcare costs of the state, how cost effective is this product? And like Dr. Tunde mentioned, with the cost effectiveness model that Smiles for Mothers developed, we have been able to use that. And you know, luckily for us, 2 of the states that are covered under their model, which is Rivers and Yobe, are some of our project states. So in speaking to these state governments, explaining the efficacy of heat-stable carbetocin, and also demonstrating that it is cost-effective, that cost-effectiveness analysis has been able to provide us with evidence to prove that point. And in my personal physical engagement with these stakeholders in the states, they have been very, very positive about the potential of heat-stable carbetocin. So, as I mentioned, we've been on this project for 7 months. Going forward, our goal basically is to make sure that we continue to strengthen the relationship with the governments in the states where we're doing this project in. And for us, it is very, very important for us to train the healthcare workers on these newer and lesser used uterotonics, because they are the ones who are in the facilities, they are the ones who see the moms, they are the ones who firsthand have the in-depth experience of seeing a mother die from postpartum hemorrhage. So training them about this product, especially heat-stable carbetocin, the efficacy of heat-stable carbetocin for us is very, very crucial, because we believe that if all the healthcare workers are trained, it would then be easier to introduce the product into the states, because they are the ones who they are the ones who demand for products that are being used in their facilities. So, and also just to add another thing that we have also introduced, because again, we are a tech logistics company, we want to make sure that these heat-stable carbetocin gets to the public and faith-based facilities, because our project basically targets public and faith-based facilities, and we're using technology to do that. So as we move these heat-stable carbetocin across the supply chain, we are tracking it using our own developed technology to ensure that the product doesn't get diverted, to ensure that the right quantity make it to those healthcare facilities. And this is very, very crucial for us, because under this project, the heat-stable carbetocin is coming at an access price. And we want to make sure that the product eventually makes it to the public and the faith-based facilities. So again, it has been a very interesting 7 months working on this project. We still have a very long way to go, but so far it has been great. We've made enormous progress, especially leaning on the example that has already been set by Smiles for Mothers. And we're hoping that as the months roll by and we continue to do more work in the 5 main states that we're working on the project in, we will make more progress and we would ensure that basically, like everyone has said here, that no mother in Nigeria has to die from postpartum hemorrhage. So, Nonso, over. Thank you.
Thank you very much, Elizabeth. That's very insightful, and I think we're also happy to hear that our contributions helped the work. So I would take a couple of questions from the audience, but I think first we just appreciate everybody that has stayed on. I see we've kept most of the people, but we are way beyond time. But I will take 2 questions from the participants for my panelists, and then we'll wrap up. So I think the first one is to you, Dr. Yin, directly. And this goes, Nigeria currently leads on PPH indices. What strategies is the government of Nigeria, NAFDAC, FMOH, MPHCD, etc. doing to work collaboratively to improve the quality of oxytocin? So I think this is speaking to collaboration, but specifically regards quality of uterotonics. So Dr. Yin.
Oh, thank you for the question. PPH, if you look at it, as a cause of maternal health, we have like 23%. So it's very top in our strategy, and we are working collaboratively with all these agencies. Apart from that, even the essential medicine list, we've just done a collaborative effort to review our essential medicine list. Then in terms of quality, we have a working group of private sector on market of reproductive health commodities. We have met twice now, looking at the possibility of a local production of reproductive health commodities. We've met twice within the last 2 months. So we are putting that also as part of efforts, so that we can also look at local production and be able to checkmate the quality of it, not only the quality of product, even the supply chain to the last mile. Sometimes the quality may come out good from the manufacturer, but the transportation, the cold chain that you need to move it, maybe from in country to the last mile, you begin to lose that. And that is where the quality begins to wear out, especially those that need cold chain environment for you to still sustain the quality. And also, based on NAFDAC, we are working very well with NAFDAC in terms of checking the standard of all these uterotonics. And not only that, that we do that, documents are being produced, policies are being made to checkmate this, the quality of uterotonics that we have in Nigeria. Apart from that, we also do regularly go to the market. The last one that was supported by UNFPA, we picked some states and we went down to the market, up to the last mile, interior, and picked samples of this uterotonic for analysis. So we did that, and we wrote down the manufacturer's name, where they come from, all the contacts, and things like that for feedback through NAFDAC from the result that came out. That result was published. So these are the efforts we have been making. But I think the most important effort is the issue of local production, so that we'll be able to make sure that both the transportation, maybe to the last mile, once it's being produced here in the in-country, will be sustained and will be checkmated. So those are the efforts we are making. Thank you.
Thank you very much, Dr. Ini. We'll take one other question. It's actually two questions I'm going to merge into one because they are both talking about, scaling up emotive specifically to other, care providers outside the typical doctors and teaching at tertiary hospitals. So the question is there a plan for massive rollout of emotive to midwives through bodies like ICM? All midwives and nurses need to be trained on this. A similar question to that is how can TPH be actively supported to employ emotive imaging deliveries in rural settings, camps, and riverine communities without a functional health facility? So I think this one is really for all my panelists. Maybe I will start with Professor Bello, since she touched a bit on the fact that we have a lot of deliveries outside the tertiary and secondary health facilities. Professor Bello.
Thank you. I'll admit that this would be out of my scope as a practicing obstetrician and a university researcher, but my ideas about it is that in the same way that we roll out implementation from the ministry level down through to MDAs to local governments is probably the way to go about this as well, both with the training and with the supply and availability of the medication and with the retraining. Sorry, that's the word I was looking for. As in, it's not a one-off training. It's never is a one-off training. It's something that will be done consistently. I would hope that Dr. Ini would have more insights into how that can be done, because implementation science is not really my thing, really. But thank you for the opportunity.
Thank you, ma'am. Dr. Ini.
Okay, thank you. We, at the federal level, we've adopted emotives, and it's already within the scope of the Safe Mother strategy in terms of interventions that will be rolled out. We are presently reviewing the life-saving skill training manuals, and that emotive will now be incorporated into this training manual. And once that is done, we'll be able to be using the training manual for all the trainings on LSS, and that will also go with it. But we need to know that if you look at emotive, calibrated drip is an essential component of emotive. And when you go to all our facilities, even the tertiary institutions, you can count the number of calibrated drip you may find. We have all been relying on a virtual estimation of blood loss. And many a time, like Prof said, by the time you now begin to count pulse, look at the BP, the patient will be going towards shock before you realize it, because a lot of blood has been lost. You could not adequately estimate. So emotive, the beginning of emotive, successfully emotive, is to be able to have a good assessment and estimation of blood loss, and it's only calibrated drip that can do that. So in moving forward, we've put this emotive into our procurement plan in the Federal Ministry of Health, and we're also looking at how presentations will be made in our coordination mechanism, the TWG, and also sell it to partners. We need to make the calibrated drip available, because you need to start on time based on calibrated drip to know the point at which you should start it. If you don't start emotive when you are supposed to start it, you will still fail, even when you have trained people. And when there are no calibrated drip, that will make them to start where you are to start. We are not using pulse rate, we are not using BP to look at the estimation where you will start emotive. So calibrated drip is the cardinal point where you know whether you succeed your emotive or you will fail, because you don't start on time. So we are rolling out, finding a way of rolling out the calibrated drip, apart from the training. so that that will be available in our facilities. So we'll be talking to some partners on it and some manufacturer, both local and foreign. So, and we have also embedded it in our procurement plan for 2024 at our side. And we're also going to engage, which they are already within the system, the NPHCDA also, for us to be able to look at it. For the TBA, in our policy does not allow TBA to conduct delivery. It's not in the national policy. And National Council of Health has not approved that TBAs should conduct delivery. Their role is to mobilize people, to mobilize pregnant women to the facilities. But some states, because of our constitution, some states have adopted delivery at home through TBA. So to those states that have done that, they need to move forward with it, all the risks that are involved, and make sure that their strategy is not counterproductive for what they have set out to do. So not to talk of if they will start with emotive in the TBA or a home delivery. So it's not part of our strategy at the national level, but because of the constitutional role of the State Ministry of Health, they have responsibility for their people at the state level. So if they've adopted TBA to be conducting delivery, like Lagos State did, and some other states that have done very well, passed law on it, then they need to take that responsibility. But emotive is not meant for home delivery. It's not meant for it. It's meant for facility delivery, according to our national policy. I don't know if I've answered those questions or clarification.
Yes, thank you very much, Dr. Ili and Professor Bill. I think your response addresses the question and also provides some, guidance as to why maybe some things might not be possible at this time. I think this will be a stop. We have actually run out of time, but I really want to appreciate all my panelists and all the presenters from earlier for really making this happen. I also want to really appreciate all the participants. I saw the locations coming in. We had participants from DRC, Guinea-Bissau, Geneva, all over the world. Really appreciate everyone. As we wrap up, I will just touch on a few things I took away from today's conversation, and I hope also resonates with all of us. We've learned from the webinar how Smiles for Mothers and LifeBank have successfully introduced histobukapitocin, which is one of the lesser used commodities we've talked about today, and how we're currently working with Federal Ministry of Health to scale this up nationwide. We've also done some interesting insights from different researches that have been done. We heard about the woman trial, the emotive trial, and the work by Concept Foundation on the cost of quality uterotonics. We've also seen how some of this research is now influencing policy guidelines and even strategy, that is now driven by the Federal Ministry of Health and WHO. And finally, I think there's still some food for thought for all of us in the space, especially around some of the challenges that would need to be considered as we look at how to scale up these newer and lesser used commodities. Specifically, some of the things that have come up, where our women actually deliver and how we can make sure these commodities cover them one way or the other. We should also consider the availability of some of these commodities, especially the calibrated drapes, and finally the quality of uterotonics. But I think, frankly, maternal health commodities in general, so that we can, at the end of the day, ensure that truly no woman dies bringing life. On behalf of the Federal Ministry of Health and Smiles for Mothers, it's been my pleasure moderating today, and I really want to thank everybody that has been a part of this. To have a lovely day. And also remember to fill our webinar survey. You can scan the QR code on your screen and expect some communication from the Smiles from Others team, which will also share some of the resources that have been mentioned. And if you have any follow-on questions, we will help you direct them to the relevant quarters. Thank you. And